Good afternoon. Welcome to the second annual CME of the Department of Community Medicine from Pushpagiri Medical College, Thiruvalla, which is being conducted as a webinar series this year. Our theme is Being in Charge, a Guide to Management in Primary Healthcare. We have planned 4 sessions of 1 hour duration to be held every Thursday from 2:30 p.m. Our speaker for today's topic is Dr. Anish T.S. The next sessions will be on the coming 3 Thursdays. On 26th of November, Dr. Resmi M.S., Deputy DMO of Pathanamthitta District, will conduct a session on our various health programs. On December 3rd, Dr. Sinia T. Nugent, Associate Professor of Community Medicine from Government Medical College, Kollam, will take a session on material management. Our final session on December 10th on intersector collaboration will be taken by Dr. Indu P.S., Professor and HOD of Community Medicine at Government Medical College, Thiruvalla. Please leave your comments and questions in the comment box and we will discuss them at the end. Today's session is introducing the primary healthcare picture and players. Joining us today is Dr. Anish T.S., Associate Professor in Community Medicine at Government Medical College, Trivandrum. Dr. Anish completed both his undergraduate and postgraduate studies at Government Medical College, Thiruvalla. He is an expert in the field of teaching public health and is presently the Administrative Medical Officer at the Integrated Family Health Center associated with the Medical College and is the head of field workers implementing various national health programs. He has more than 35 research publications with 430 citations in indexed national and international journals to his name. He is currently on deputation as Public Health Consultant for the Kerala State Disaster Management Authority and is serving as epidemiologist in the state expert panel of COVID-19. It is my privilege to ask you to join me in welcoming Dr. Anish T.S. Sir, over to you.
Thank you. Why there is a sound in between, something like a bell ringing sound? Can you hear me?
Yes, sir, we can hear you. Yeah, we are working on stopping the sound, sir. 1 minute, please.
Okay, anyway, we will start. I shall share my screen. Okay, thank you for inviting me for this webinar. My topic is primary healthcare, picture and players. Especially our major topic, I think it is public health management. Nowadays, public health, rather community medicine, has got two very big arms. One is epidemiology, and second one is public health management. Okay, epidemiology, we are dealing with distribution, determinants of health-related states and events. And in public health management, we are strategizing managerial techniques so that we can control these kinds of diseases. So both are very important areas in practicing public health or community medicine. So the second half of this domain, that is public health management, is very important. And among many strategies that is available, primary healthcare is something, it is a passion for most of the public health experts all over the world because it is very close to their heart and it is very important, and it is actually placing health in the heart of community. When we are thinking about health has got different aspects. Especially two aspects of healthcare is there. One is the individual dimension of health, and second one is the community dimension of health. Individual dimension of health means if each and everyone in a community is seeking health, and if they are able to seek health, definitely the health care or the health status of community will be improved. The second aspect is sometimes there will be so many marginalized people. And when you are thinking about the availability, accessibility, and affordability matrix, each and every one present in this community, there may not be a health center or a health facility available to them. Sometimes it may not be affordable to them. Sometimes because of maybe cultural conflicts and all, some things may not be accessible. So we better you plan healthcare at a community level so that every individual can enjoy and the community as a large or as a whole can be benefited out of that. So primary healthcare is such a philosophy that we are keeping health in at the community level so that we can devise strategies so that it will improve the health status of the community, and in a larger aspect, it will definitely help the individual to take care of their health also. So primary healthcare is not a new concept. It is actually a very old concept. It maybe it has got, it started somewhere in 18th century in Europe, the concept of something like a primary healthcare. But that did not have that name during that time of evolution. Rather, it is actually a strategic change or a change in philosophy that the community as a whole should be taken care of if you want to improve the health status. Especially that is evolved, as you already know, it has evolved in the context of cholera outbreaks of London. So James, you know the history of Chadwick or Dr. John Snow and all others. They were trying to find a solution for cholera. And at that point of time, each and every individuals were seeking care, whatever available care that is available to them. But we found that it is not able to pick up the health status of the community by concentrating on individuals. So we thought, okay, this is an aspect of health that health may be improved by the upliftment of the community as a whole. So when we were planning our health system for India, maybe way back in 1946 by Boer Committee, and Boer Committee was giving another name for this approach that is known as a basic healthcare approach. But in Alma-Ata Declaration that was happening in 1978, it has got a very good shape that it is named as primary healthcare. Okay, even though the concept is there, even before maybe India's independence, but primary healthcare has got a very theoretical framework and a very good structure by Alma-Ata Declaration that has happened in 1978. While we are going through a community medicine textbook, for example, PARC, there are more than one chapter is there on the specific area that is primary healthcare. But I don't know how much we medical students or medical practitioners understood what primary healthcare is. So I think I can start my lecture going through the philosophical aspects of primary healthcare that is given in Alma-Ata Declaration. Alma-Ata Declaration, that document itself is actually a very small document. Everybody can go to internet and read. It is available in WHO website. It may be, in size, it is less than that of the chapter on primary healthcare given in PARC. So better you go through the document in WHO website on Alma-Ata Declaration and you learn what primary healthcare is. Some of the major aspects I have included in my presentation. So before going to that, you know somebody who is in the right-hand side. You can see the picture of Sir Rudolf Virchow. Sir Rudolf Virchow is better known to us as father of social medicine. But for a pathologist, he is father of pathology. We often wonder while we go through going through the medical curriculum, sometimes we will wonder that there are more than one Virchow there in the history. Because when you are reading a medicine textbook, you will be seeing a Werkho's triangle, maybe a Werkho's cell. In pathology, again, you are seeing Werkho's contribution. But when we are coming to community medicine, there is a German doctor named Rudolf Virchow, who is known as father of social medicine. So whenever we are thinking about or we are speaking about primary healthcare as a concept, I think we have to keep his name in our mind, because he's a very ancient or a pioneer in primary healthcare concept. So his report on Upper Silesia report on typhus is considered as one of the Magna Carta of primary healthcare. So you may be knowing the story that Bismarck was a contemporary to Sir Rudolf Virchow. And when there was a big typhus outbreak happening in Upper Silesia means some part of Hungary, Vienna, and maybe Czech Republic and all those places. So in Upper Silesia, there was a typhus outbreak. And Upper Silesia at that time, maybe at the last part of 19th century, was in the Prussia Empire. And Rudolf Virchow was sent to Upper Silesia to investigate on the factors associated to the typhus outbreak, or what are the remedies for typhus. And these are some of the statements in his Upper Silesia report. And we are actually taken a very important statement from that report, that medicine is a social science and politics is nothing else but medicine on a large scale. Medicine as a social science, as the science of human beings, has the obligation to point out problems to attempt their theoretical solution. And politician, the practical anthropologist, must found the means of their actual solution. Medicine is a social science and politics is nothing but medicine. That is the often quoted statement of Sir Rudolf Virchow. And when you are going down the line, you can observe that it's a very how clearly he has explained that politician is a practical anthropologist, and he is realizing or the concept given by a doctor. That means even in Kerala or in other part of India, maybe, it is a very important dynamics between a doctor and a politician. Suppose you are working in a PhD level, you have to be a very good contact with the politician. Politician means who are able to administrate the field in that particular location. So suppose you have got an idea, it is very important person. The politician is a very important person to make it a reality. Often we will be discussing that when I am studying as a medical student for my MBBS classroom, I heard that the most important killer disease for children is diarrheal diseases. But now for a medical student, now studying in a medical classroom, he may be hearing or he may be learning that number one killer disease for children is lower respiratory tract infection, that is pneumonia. And diarrhea is actually the second one. And when we are comparing the incidence of pneumonia and diarrhea, diarrhea has got an incidence just half of that of pneumonia. What happened to diarrhea, diarrheal diseases and diarrheal deaths? When you are thinking about the last 25 years, you may find that the total diarrheal deaths were coming down to less than maybe 1/4 of that was present 25 years before. What was happening to the diarrheal outbreaks or diarrheal deaths? It has substantially reduced. What was the reason? Is it some doctors treated diarrheal diseases with antibiotics? Was it the reason? Or we have found a very wonderful tool to prevent death among diarrheal diseases, that was ORS. Is it the wide use of ORS is the reason for reduction in death rate due to diarrhea among children, or something else? So somebody has actually conducted an investigation on that by studying the health system of all over the world, especially of African and Asian countries where there is so many diarrheal deaths were happening. And they found that even it is not ORS, is not responsible for this much reduction in diarrheal deaths. Definitely ORS has got its effect on reduction of diarrheal deaths. But the major contributor was not ORS, but it was good quality drinking water or potable water supply that was given all over the world. When we are thinking about Kerala also, it is very evident that the Kerala model of health is highly depending upon the social determinants of health rather than a doctor or a nurse treating some illness and curing it. It is not that we have achieved over the years. Why our infant mortality rate is much less than that of other countries or other states? No, not because of a treating doctor, but because of a public health interventions that happened knowingly or unknowingly in this field. Okay, Dr. C.R. Soman used to say some of these interventions that has happened in Kerala. For example, in Kerala, one of the most common diseases that was present in middle part of 20th century is thyroid diseases, especially hypothyroidism and goiter. It was prevalent in the eastern part of Kerala because there is high rainfall, and because of high rainfall, water used to wash away the old halogen elements in the soil, and the soil in Kerala is except in the coastal area, the soil is devoid of iodine. So the vegetables cultivated in Kerala is usually deficient in iodine. So then what happened to us? Even before you have introduced iodized salt, the reduction has already happened in thyroid diseases, especially hypothyroidism and goiter. What was the reason for that? Dr. C.R. Soman likely he was contributing Indo-Norwegian fishing technology was the reason for reduction in goiter in Kerala. Similarly, so many things are there. In Kerala, there was another disease which was very prominent, or it was very widely present in Kerala, maybe in the middle of 20th century. That is chronic pancreatitis, chronic calcifying pancreatitis and pancreatic diabetes. And nowadays, we do not find so many cases of chronic calcifying pancreatitis, especially among non-alcoholics. And we are very rare that we are finding pancreatic diabetes also. The reason for these diseases were thought to be increased intake of tapioca, especially the tapioca which contains high amount of hydrocyanic acid. But now we do not have that kind of an experience in Kerala. And what made the difference is the PDS system, that is public distribution system, which made available rice for each and every families especially among poor people of Kerala. So the community intervention, especially the political intervention, has got much to do to reduce the disease burden and to improve public health of the community. But definitely, as a doctor, okay, we have got an obligation to point out problems and to attempt their theoretical solution, so that the politician, as if he is committed, he can go for the implementation of the actual solution. That was the concept given way back in last part of 19th century by Sir Rudolf Virchow by his Upper Silesia report. So whenever we are speaking about primary healthcare, it is poetic justice that we will start with the story of Sir Rudolf Virchow. So these are some of the contents in his reports, and we can see that he is not actually speaking about typhus fever, rather than he is speaking about the extent of poverty that was prevailing in Upper Silesia at that point of time. And he was suggesting, okay, as a medicine, how can you cure typhus outbreak? He was suggesting you have to give at least partial freedom for Upper Silesia. Okay, if your country is not having freedom, definitely if you are ruled by somebody else, definitely your country, there will be a lot of communicable diseases, and maybe non-communicable diseases are also there in your country. And when even now, if you look at the disease prevailing in almost all other part of world, for example, where Ebola is prevailing, maybe where this communicable disease. Suppose you look at polio, and you will see that the governance mechanism is the most important factor, which has uplifted the health of certain communities. Whenever you are comparing the health status of Scandinavian countries and that of sub-Saharan Africa, you will find that the infant mortality rate in Scandinavian countries are less than 5, and in the infant mortality rate in sub-Saharan countries, Saharan African countries, are something near to 100. Why out of 1,000 children, less than 5 children are dying in Scandinavian countries, rather 1 in 10 children is dying in some of the African countries? Okay, is it because of the children are not taken care of by their mothers? Or is it because the mother is not giving breast milk to the child? Or is it because of something else? If it's because of the availability of health the facilities, maybe doctors. Ultimately, we will find that it is basically the governance and the governance mechanism that is playing in the difference. Definitely money and all other things are determining these kinds of things that we have to agree. But definitely health, whenever you are viewing health, definitely you have to view the distal determinants of health so that you can change the entire the paradigm of health. Okay, you may be aware of these two types of approaching a health problem, the proximate determinants and distal determinants. Proximate determinants means you are approaching the disease very proximately or very close to. For example, you are looking at tuberculosis, and very close to tuberculosis, what is the risk factor or what is causing tuberculosis is tubercle bacilli. So if you want to do something on tuberculosis, you do something on tubercle bacilli. You kill all the tubercle bacilli, maybe given by drugs or something, and tuberculosis will be gone. That is the approach. It's actually based on the proximate determinants. But whenever you are looking at tuberculosis, and you will see that tuberculosis is largely a poor man's disease. It is happening in countries which are poor. Even inside the countries, it is happening to poor people. It is actually happening to smokers. It is happening to most uneducated people. It is happening to mainly it is happening in elderly and all. So if you want to address tuberculosis, you have to address poverty. If you have to address you have to address the living condition of people so that the tuberculosis will be addressed. The benefit of this kind of an approach is that if you are addressing the poverty and if you are addressing the living condition of people, not only tuberculosis, it will take away measles, it will take away malaria, it can even reduce the burden of diabetes and hypertension. So that is the importance of approach through distal determinants of health. And primary healthcare is actually giving a concentration, or it is actually giving an importance for the distal determinants of health. And again, it is through the community participation and community involvement and using the resources that is available in the community itself. So, Alma-Ata Declaration say about primary health care. It has got only 10 points. I am not giving all the details given in 10 points because I cannot include that in the slide set. But it is actually a very small document. It has only 3 pages and you can go and read. But I will give you a glimpse of what Alma-Ata Declaration says about primary health care. It starts with first point, even in Astana Declaration. Astana Declaration is the continuation of Alma-Ata Declaration that has happened in 2018. So Alma-Ata Declaration was happening in 1978. And as a continuation, Astana Declaration in 2018, both are on primary healthcare. And both document has got a similarity. It has got a very close similarity to each other. But one of the most important similarity in both documents, the first statement is health is a fundamental human right. So it is an interesting fact that even in 2017, our national health policy, there is a paragraph that health should be considered as a fundamental human right, but it is given to the state's priorities. If a state now, according to 2017 health policy, a state can decide whether they have to keep health as a fundamental human right. Even in Kerala, we did not keep health as a fundamental human right. I think some of the Indian states, I think Rajasthan or some states, has kept as health as a fundamental human rights, maybe the last couple of years. Then why they are not considering health as a fundamental human right? Okay, why Kerala cannot put health as a fundamental human right? Because if you are keeping health as a fundamental human right, your constitution is giving you some kind of somebody is actually drawing. Okay. If health is kept as a fundamental human right, what is happening? That your constitution is giving you a protection against ill health. Okay, because fundamental human rights are very important, so that you can approach a court, you can file a habeas corpus. Okay, if your fundamental human right is violated, suppose somebody is arrested you because without any legal ability or legal provision to arrest you. Okay, you can approach court. Maybe in a WhatsApp you can send a message to the magistrate that somebody has kept you in custody and your fundamental human right is violated. So even you can directly go to Supreme Court. That is a very strong argument that your fundamental human right is violated. So if you are keeping health as a fundamental human right, then if some kind of your health care is violated or something like that, you have to be given huge compensation, and health will be maybe in the heart of law. So that may be the reason that we are not keeping health as a fundamental human right in reality. But Alma-Ata Declaration in 1978 itself is arguing that health is the right of a person. If you are born in this earth, health is your right. Okay, if you are not able to enjoy health because of the community where you are living in, or maybe because of some other reason, you are not responsible. It is your birthright. So it is the duty of the governments and the community that your health is preserved. So second one is the existing gross inequality, that is known as health gap. Health gap is actually the context of Alma-Ata Declaration, or the WHO General Assembly meeting that has happened in Alma-Ata 1977. The very reason is health gap that we have already discussed, with the example of Scandinavian countries and that of Sub-Saharan Africa. So when you are looking at all over the world, everybody is having got a similar kind of birth. Everybody are human beings. Everybody has got the right to live. But in some part of the world, your health care is much better, and some part of the world, the health care is not much better. Even inside a country, in some states, it is much better. In some states, it is not. Even in a state, in certain communities, it is not better. And for example, in tribal community of Kerala, maybe it is actually lagging behind the mainstream. And we know in the context of COVID that what has happened to our coastal area. Our coastal area is very much lagging behind to the mainstream in case of health. Even in a particular locality, you can see that in some families, they have got a very good access to health, but some families do not. So these kinds of things are known as health gap. So Alma-Ata Declaration, as an output of primary health care, is considering the bridging the gap in the health gap or gross inequity in health. And third aspect is the economic and social development is the basic importance of fullest attempt of health. If you want to achieve health, It is only through economical and social development. When we are looking at PARC was divided. The primary healthcare has got 4 principles, and I don't think somebody argue that how can you say that these are 4 principles. When we are saying primary health care has got 4 principles, it is somebody's assessment of primary health care. I don't think it is wrong, but if you consider, okay, a 5th principle is there, and this is the principle according to Alma Ata Declaration, that is also a right answer, because Alma Ata Declaration doesn't say that primary health care has got only 4 principles. Definitely, as an undergraduate, you can say it has got 4 principles. But for a postgraduate, we cannot say it has got 4 principles. If you learn, suppose health is a fundamental human right, is the 5th principle, or even that is the 1st principle of Alma Ata Declaration, or the primary health care, it is not wrong. So again, the economic and social development is actually very linked to that argument in PARC, that is intersectoral coordination. Intersectoral coordination again repeated in the document. Okay, the 4th one is the people have the right and duty to participate individually and collectively in planning and implementation of their healthcare, community participation or something like that. Okay, the numbering, I think it has gone. This is the 5th one. The government has the responsibility for health of their people. That means it is not the individual's responsibility of that has got a problem. I have happened to hear a talk by Dr. John, who is Dr. Matthew John, who is he's from Vellore, and he's a very famous person in vaccinology and all. One of his argument, I think it is very, very much right, that we are considering a blame. We are considering, for example, a person has got diabetes. Why this person has got diabetes? We usually think that, okay, this is because of it was his responsibility to keep him healthy. It is nobody's responsibility, but it is your responsibility to keep you healthy. Suppose you have got COVID, you did not wear mask and you were not taking care of the government's instruction in COVID. That is why you are getting COVID. Suppose you are getting diarrheal disease, it is because of your insanitary conditions that you kept. That is the reason for your diarrheal condition. In each and every disease, we think that individuals are responsible for their health. That is not actually a very good approach, because maybe one individual may be responsible for his or her health, but when you are looking at the mean, you can see that, okay, in Kerala, the healthcare has got this much status. For example, Kerala has got an infant mortality of 15, and you look at another state which has got an infant mortality of 50, 15 versus 50. In Kerala, according to the National Family Health Survey last, the infant mortality rate is less than 10. So I am actually taking that statistics. In Kerala, it is 10, and in some of the Indian states, it is 50. Why 5 times higher the death rate among children? Is it because of the responsible or irresponsibility of the mothers of the child, or is it because of something else? So you cannot say that health is the responsibility of people. At a large, health is the responsibility of government. So and government should take the responsibility of health. That is a very important aspect of primary health care. It is envisaged by Alma Ata Declaration. And again, maybe the 6th one, primary healthcare that is the definition of primary healthcare as we consider in PARC and all other textbooks. It is nothing wrong that if you consider this is the definition of primary healthcare. But in Alma Ata Declaration, they are not saying that this is the definition of primary healthcare, but this is the part where we can consider maybe a definition of primary healthcare. Primary healthcare is essential healthcare based on practical and scientifically sound and socially acceptable methods and technology made universally accessible to individuals and families. Okay, you can read it in your textbook. And again, they are dividing primary healthcare into 7 components in Alberta Declaration. Okay, it has got different components. One is primary healthcare reflects and evolves from economic conditions and socio-cultural and political characteristics of country and its community. It should come from the community. Your healthcare mechanisms, your healthcare plans, and all those things should be based on your community. That is one thing. Second one is it addresses the main health problems in the community. And suppose you have to learn about your community and what are the problems you have. And you have to develop your own promotive, preventive, curative, and rehabilitative services. Then the third statement, it have to taken care of the education, health education, the control of locally endemic diseases, it's immunization, maternal care, nutrition, sanitation, and all other things that we consider as elements of primary health care is described in this portion. And again, somebody has read this article and they formulate that these are the elements of primary health care. In Alberta Declaration, there is no statement that these 8 things are the elements of primary health care. And again, they say that it should evolve. In addition to health sector, there should be intersectorial coordination. It requires maximum community and individual participation. Health team should be there. Okay. In a health care of a community cannot be built by a single person. There should be a health team and all those things are given. Okay, these are the major things. I'm not going to very much details. You can go through and learn what is primary health care as conceptualized by Alberta. That is a very important exercise that you can do. Maybe if you are a PG student or a faculty, definitely you have to go through and learn. And then this is in 1978. 2008 is the most important, another year in the evolution of primary health care. In World Health Report 2008, which is again in people in the field of public health are celebrating very much on the World Health Day report of 2008. 2008 has got another importance that 2008 is the year where the Commission on Distal Determinants of Health by WHO was constituted. So 2008 is a very important year. And in 2008, in World Health Day report, you can see a very important table, and I am actually putting that table. They are redefining the primary health care. Okay, in primary health care, they are mentioning essential drugs should be available. But in current primary health care, it is based on a social health protection. It is not what is essential drugs. If you look at the WHO's list of essential drugs, you will see that most of the drugs that we used are not essential drugs. They are semi-essential drugs. Most of the antibiotics, most of the antihypertensives are semi-essential drugs only. So we cannot delay, or we cannot actually depend on the essential drugs. Then you look at our PHCs. Maybe people from Kerala can go and see how many drugs we are giving. And maybe in Tamil Nadu, drug corporation, they are giving a lot of drugs to take care of their health. It is not the essential, it is not in the essential drugs alone. So essential drugs, it is not primary health care that you just give the essential drug. You give the amount of drugs that is available for your society to keep healthy. That is the important aspect of that. And second one is the concentration on mother and child. Whatever things we consider as elements of primary health care is no longer the elements of primary health care. It is definitely mother and child is very important, but we are not giving that much concentration on mother and child, rather than we are concentrating on everyone's health. Okay, when you look at the NCD burden of maybe our country, the problem with mother and child, it may not be that much heavy. Maybe especially in Kerala, I don't think the mother and child problem is more important than the NCD problems that we have. So from the mother and child health, they are suggesting a shift to health for everyone. Then focus on locally endemic diseases, a comprehensive both risk and illness. Because nowadays, no diseases are locally endemic. When now we are thinking about COVID, do you think COVID is a locally endemic disease? Suppose you look at the health problems of Kerala or rather India, maybe communicable disease, you can see that this is not a locally endemic disease. A locally endemic disease may be applicable for a tribal population where maybe a cutaneous leishmaniasis is endemic in those localities, or in a particular area where a peculiar form of another fungal infection or something is there. Otherwise, there is no meaning for locally endemic disease, but we have to go for a comprehensive both risk and illness strategies. Even we have to concentrate on primary healthcare, maybe primordial healthcare, so that the locally endemic diseases are not occurring at all. So rather than locally endemic diseases, we are actually shifting from, I think, again, I repeat that what we are learning in PARC textbook is no longer very relevant. What are the components of primary healthcare? We have to control locally endemic disease. We should have essential. It is not like that. Primary healthcare has actually grown from that kind of a rudimentary state to a higher level. Then hygiene and health education should be shifted to healthier lifestyles. Hygiene and health education, it is not only enough. There are more. For example, healthy food. Okay, where in the primary healthcare, in the PARC textbook, they are speaking about healthy food. So healthy food is a very important thing. It is more important than maybe hygiene and health education. So all healthier lifestyles should be incorporated. From the volunteerism, we are actually calling for professionalism for appropriate technology. This health is not a cheap business. So we have to get professionals, and definitely we can take care of or we can use volunteerism, but definitely health is a professional area. Community involvement rather than community participation, it should be happen to community-driven approach. It's usually central top-down management from pluralistic health systems. Okay, one person is planning your healthcare and implementing. It is not. It is you have to hear from all the systems and you have to build your own health system. Management of growth of resources, then guiding the growth of resources for health. Cheap and need only a modest investment. It is not cheap. Primary healthcare is not cheap. It is actually giving better value for money. Okay, it is giving you output, which is more than that of input. That doesn't mean that the input is less. You have to give good input, then only you will get a good output. So that means whatever you have learned in primary healthcare based on PARC textbook is not relevant after 2000. It is less relevant. I am not saying that it is not relevant, but it is less relevant after 2008. So that is a very important aspect of primary healthcare. This is WHO's report on social determinants of health in 2008. I am not going to details. So what has happened by the turn of millennium is when from the MDG, we have shifted our area to SDG. When you are looking at MDG and SDG, when you are comparing MDG and SDG, we can see that the health has got less priority in SDG. SDG is actually more broad and where they are taking care of or taking into account so many dimensions in the purview of development that may be good. But health is a very important dimension. That is the goal 3, that good health and well-being. When you are following this one, this is Alma-Ata Declaration in 2018. Again, you can go and see what is in Alma-Ata Declaration, Astana Declaration, that is in 2018. Astana is another place, another city in the same Kazakhstan, where Alma-Ata is also located. And it was happened at the 30th year of Alma-Ata Declaration. It is very similar to Alma-Ata Declaration. They are re-emphasizing their concentration on primary healthcare. It has got a political context also, because during this time, rather than primary healthcare, another term was where in the mainstream. That was UHC. that is universal health care or universal health coverage. So there was a big debate between primary health care and universal health care. What is the difference between universal health care and primary health care? Universal health care is concentrating more on curative aspect of health compared to primary health care, which is giving more emphasis on the preventive aspect of health. Primary health care is not speaking much about money. It is speaking about resources, definitely, but it is not speaking much about money. But universal healthcare is speaking much about money. So for a capitalist economy, it is more likely that universal healthcare may be sell or sold well compared to a primary healthcare strategy. So the most of the political strategy that WHO put forward by Astana Declaration is combining the primary healthcare and universal healthcare, and they have to assert that universal healthcare is nothing but it is primary healthcare. It's modified according to the newer challenges and all. So Astana Declaration in 2018, there's actually some of the statements from the document itself. Okay, they are addressing governments and societies, primary healthcare and health services, enabling and health conducive environment, partners and stakeholders. These four things are there in the preamble itself. They are addressing these things. And again, the first one is health is a fundamental human right. Okay, this is one common thing that we have already discussed. Okay, then they are saying that we are convinced that strengthening primary healthcare is the most inclusive, effective, and efficient approach to enhance people's physical, mental health, and social well-being. Then people may ask, then what is the scope of UHC? They are saying that PHC or primary healthcare is the cornerstone of sustainable health system for universal health coverage also, and to attainment of health-related sustainable development goal. So in this context, Astana is something, it is acting as an amalgamation, or it is acting as a glue between primary healthcare and universal healthcare. And again, they are speaking about a lot of problems that we are facing. I'm not going to details. And Astana Declaration say that, okay, they are committed, or WHO or primary healthcare philosophy as such is committed to make bold political choices for health across all sectors and all other things that you can go and read. So definitely, we are speaking more about universal healthcare, maybe as an appendage of primary healthcare redefined. But some of the economists and some of the public health person are actually swallowing it with a pinch of salt. But again, there is I think I have to talk something about UHC also. So UHC means that all individuals and community receive health services they need without suffering financial hardship. Okay, they have to get the healthcare, and the money should not be coming from their pockets. Okay, the money should be coming from the pooled resources, maybe from government or some other kind of pooling of resources should be there. UHC don't think or don't compel that the government has to put money. It only compel that there should be a pooled resource. That's okay. It can be by a community insurance scheme, or even it can be by a private insurance scheme. Okay, it includes the full spectrum of essential quality health services from health promotion to prevention, treatment, rehabilitation, and palliative. Again, health has got these aspects: health promotion, prevention, treatment, rehabilitation, and palliative care. But whatever money spent by the individual or the family should be given from a pooled resource setting, maybe by government. So that is UHC. So one criticism for this one is, suppose if you are saying like this, automatically the focus would be shifted to the right-hand side. That means the treatment side rather than going for the prevention side. Because prevention is not it has got less material benefit compared to treatment. Suppose how much money I have spent to prevent a diarrheal disease, how much money I have spent to prevent COVID, how much money government has spent to prevent the COVID for me, how much money a pharmaceutical company has spent to not getting COVID for me. You cannot account that. It is very difficult to account. It is very difficult to showcase also. But how much money the government has spent to treat my COVID, how much money a pharmaceutical company has spent or gained by treating my COVID, it is a very clear situation. Okay, this is about UHC. UHC enables everyone to access the services. It is protecting people from financial consequences of paying for health services out of their own pockets. Achieving UHC is one of the targets the nations of world set when adopting sustainable development goals. So these are the things go hand in hand. This sustainable development goals and our UHC. What is UHC is not, I am not going to very details of UHC. Okay. Okay, this is the WHO strategy, or rather WHO's matrix to measure UHC. Okay, it has got 4 categories and 17. In WHO document, it is given as 17 essential services, but actually if you count, you will find that there is 17. WHO documents say it is 16, but while you count, you will find that it is 17. UHC is measured. If you just look at the domains and see how much money is coming from your pocket, how much money is coming from some kind of a pooled network or from government, and you just look how much UHC is there in your locality. In reproductive, maternal and newborn health, the cost of family planning, antenatal and delivery care, full child immunization, health-seeking behavior for pneumonia. These are the major indicators. In infectious disease, tuberculosis, HIV treatment, hepatitis treatment, use of insecticide-treated bird nets, adequate sanitation. Okay, you look at in one indicator, that is adequate sanitation, is purely health promotional. Another indicator, use of insecticide-treated bird nets for malaria, may be a specific intervention for prevention. All other things are basically treatments. So if you count how much interventions are in prevention side and how much interventions are on treatment side, you will see that, okay, this is more towards inclined towards the secondary and tertiary prevention rather than primordial and primary prevention. So that is the thing that I have to speak about UHC. You may be familiar with this diagram, that this is UHC cube, maybe most important or a most famous picture in UHC. This is how you look at UHC. Okay, how much, it has got 3 axes. One is the services. For example, your immunization service is taken care of by government, but suppose you have your cancer care, it is not taken care of by government. So how much treatment is covered already by UHC? How much of the cost is already covered by UHCs? All these things are there in 3 this axis that you can see, and you can see a inner small cube, which is the current money that is given by the government. That means all other spaces in the outer cube is coming from your pocket. So the entire aim of UHC is to make big the inner cube big, so that it will grow and it will fill the entire outer cube. You may be familiar with these kinds of concepts, though I am skipping those slides. This is another document by WHO. If you have got time, you can go through and read. This is a very important another aspect of UHC and SDG. Sustainable Development Goal has got 17 goals. Okay, only the third goal focus about health. SDG 3, third goal is focus on specifically on ensuring healthy lives and promoting well-being of all ages. You look at the target 3.8 or SDG. One of the target of SDG 3 is the achieving universal health coverage, including financial risk protection and all other things. Okay, and some of the experts believe that this is the heart of SDG. It is rather than it is this is the heart of SDG, the target 3.8. The whole other targets of health and even all other goals of SDG may be achieved by achieving the only one target, that is 3.8. So this is the map which is showing that how much coverage is reached all over the world, and you can see India is pale. That means UHC coverage is not much less according to the indicator 3.8.1. 3.8.1 is coverage of essential health services. That means UHC is not given the essential health coverages in India. India is a highly privatized market that you may be knowing. Okay, how much amount of GDP is spent on health in India? It is somewhere around between 5% to 6%. 5 to 6% of GDP in India is spent on health. That is a small amount, but not very small. Many countries are sharing almost similar amount of money in health. And India is a big country, and as if we can pool our resources, 5 to 6% of GDP is a big amount, and it can change the entire health paradigm of the country. So definitely you have to increase more resources in health, that is right. But the 5 to 6%, the rational use of this already used money is a very important aspect in India. But the problem is the government spending on health, okay, rather than the federal government spending on health, that is a union government spending on health, it is just more than 1%. It was less than 1% because of NHM and all. Now it is just more than 1%. Out of the 6% of money spent on health, most of the money is spent by people themselves from their own pockets. That is the real issue in the health scenario of India. Even you look at the arguments that IMA is putting forward, they are saying that India has to increase the budgetary allocation of health, and India has to spend more amount of GDP. That is right, definitely yes. But the real problem of India's economical deprivation in health is lack of government funding on health. So that is a very important aspect, and you have to look at the picture, and you can see that in most of the other areas, the government is actually spending money. Most of the European countries, you look at the European countries, it is dark green. Australia, it is dark green. You look at US, it is Canada. Even you look at the big South American countries like Brazil, all are largely green. That means the spending is mostly by government. Even in US, you may be thinking that, okay, there are so much private companies are there. This is on private, that is a health system running on private insurance scheme. But for that private insurance also, the biggest buyer is the government. Government is buying policy for their people. So in India, you can see that our situation is very pathetic. So that is one thing. And this is about the indicator 3.8.2. What is the indicator 3.8.2? Is the proportion of country's population with the catastrophic health expenditure. And you can see that our population is suffering from catastrophic health expenditure. Whatever threshold you have used, you can see that India is facing catastrophic health expenditure. So that is the situation that we are facing in India. We are, according to UHC, we are facing catastrophic health expenditure, but our government spending is much, much less compared to any other countries. And again, our GDP spending is also comparatively very low. So this is the thing I have already communicated, that the 3.8, that is universal health coverage, can improve health. Through that improvement in health, it can increase, or it can help SDG to achieve all other goals, at least most of the other goals. Some of the goals are given in this picture. Okay, I can share these slides if you want, because lack of time, I am actually going forward. Okay, now we look at the picture of India that we already discussed. Okay, the quality of health services are inaccessible to 70% of people. Annually, 63 million incurs catastrophic health expenditure. There is low insurance penetration, just comprehensive insurance, if you think about 17%. Most of the money in GDP spent on health, more than 60% is from people's pocket. And there is a lot of disparities and inequity issues that you know that even in Kerala, we are facing that. In Trivandrum Corporation, we are facing that. The coastal area, there is for thousands of people, they have got only one hospital, but in other part, there are many hospitals for the same number of people. So many disparities and inequity issues are there. Inefficiency of public health sector. So management problems are there. So many issues are there for our. And again, we are facing a lot of challenges. Our demographic transition is a big challenge. Kerala is really facing it now, but another part of nation is also going to face it in the near future. You look, if you are taking a cutoff of 65 years, maybe almost 10% of people are having an age more than 65 years in India, almost 10. But in Kerala, it is somewhere around 16% or 17% now. India will also reach to that kind of a level. And as the burden of old age people increases, definitely there will be new challenges evolving. And it will be very difficult to manage also. Because communicable diseases are easy to manage. Just by it is easy to manage, less resources is needed, and it is long lasting also. Whatever things you have done, suppose if you have given good quality drinking water, the diarrheal diseases will be coming down, and it is going to be there in the low level for a long period of time. Maybe for the you need not to think about the complications. But what is going to happen if you sustain the life of diabetes people? So you have to ensure the continuous supply of drugs. There can be complications. There can be kidney failure. So as a complication, as you are sustaining diabetes people, definitely you have to find out facilities for other treatments like maybe kidney transplantation. Sometimes other things are also needed. And epidemiological and nutritional transitions are occurring. Nutritional transition is it's another reality. Again, people are becoming sick. Obesity and all other things are actually going up. In some of the other locations, anemia and malnutrition are also going up. There is a managerial transition is occurring, and it is very difficult. The old world problems and old world management systems are taken, that is overtook by managerial transitions, like, for example, corporate hospitals are coming up and all those things. There is political transition that you may be aware that from a Nehruvian concept of health and welfare, we are moving to another aspect. And the federal nature of India's polity is another issue. It has got some positive nature and some negative aspects. And you know that health is a state subject, and the government of India has got its limitation to influence or involve in health sector of each and every state. And unregulated private sector is another headache for India. Recently, we had our clinical establishment bill, and if you have got time, you just go through the clinical establishment bill, and you will see that it is too inefficient to control the unregulated private sector. Maybe because the bill is prepared with the even involving the private corporates also. And per capita spending on health is another issue, especially that in Kerala, our spending has gone. Even in India, the per capita spending has grown much. Okay, we can look at the statistics and you can see coverage indices compared to, you just look at China, and our health system is much less than that of, it is not performing even that of China. And you look at the proportion of GDP spent on health, according to this table, it is 3.9 in India. I think it is the government altogether, maybe central, state, and local self-government. It is India's GDP or spent on health is, I think it is more than 5%, as I have already discussed. So in India, I think we can have a lot of case studies, how we manage or mismanage things and all those things. I'm not going to detail some of these things that we can discuss if you want. One is the national, for example, National Malaria Control Program 1953. The whole public health system of Kerala or India is evolved, or it is developed on the basis of National Malaria Control Program in 1953. Our field work is prepared, or it is planned according to the malaria control. It is based on the extrinsic incubation period of malaria, that is somewhere around 15 days. And our field workers are planned to go to each and every houses. At least there will be one field worker, one in 15 days. That is coming from National Malaria Control Program. And what happened to National Malaria Control Program, that we know that now the malaria cases came down much, but there is some issues. One is high amount of insecticide resistance among mosquitoes. And second one is almost all our Vivax malaria were shifted, or it is converted to falciparum malaria. And we do not have much reduction in malarial death. Malaria case were coming down, but we are facing drug resistance, and we are not able to reduce the malarial death because there is a shift in the parasite causing malaria from Vivax to drug-resistant falciparum malaria. Again, another case study that we can discuss is National Family Planning Program. Again, it was started in 1953. In 1953, as a part of first 5-year program, we started only 2 national health programs. One is National Malaria Control Program, and the second one was National Family Planning Program. And India, in our textbook, it is shown that India is the first country to start a family planning program. And I don't think there is nothing much to celebrate on that, because it is not actually very good to say that we have started a national program to reduce your population burden. So India's National Maternal and Child Health Program, which was started in somewhere in 1980, and we took maybe 27 years to go for a program for mother and child from a family planning program. So National Family Program was not a good success, that you may be knowing. And because of that, we actually changed the program in 1977 after emergency, and it was renamed as National Family Welfare Program. Then it was actually mixed with the Mother and Child Program. It was a success after the mixing happened. That means family planning should be taken care of, or it should be viewed only through the health of mothers and child. It cannot be, there cannot be a standalone family planning program. So that kind of learning has happened maybe in India over the years. A National Tuberculosis Control Program is another example, and it was not a good success because of the inconsistency in drug supply and managerial system. But after the implementation of RNTCP, National Tuberculosis Control Program, it was actually a success. So whenever you look at the public health system of India, you will notice that there is so many irregularities and so many managerial flaws in the development of those programs. But now I think it is much better compared to the ancient times. And now I think our health system is much better, maybe because of the new initiatives like NHM and all other things. So I'm not going to details, but in some new initiatives are very promising. For example, NHM, as we have already discussed, and there is Ayushman Bharat and Karunya Arogya Suraksha Paddhati, CASP in Kerala. CASP is the Kerala version of Ayushman Bharat. Both are having some good things. For example, for Ayushman Bharat, they are actually, at least our people are given the capacity to buy a package of 5 lakhs. That is something, it's actually very great. But is it our health system can give that much amount of money for a person? That is another thing. Or is a poor country, and how much we can give. So in India, at a large, it can be possible because the reported morbidity in India is much less. And suppose 1,000 average Indians are there, the reported morbidity maybe in 50. Out of this 50, maybe 25 will be coming to hospital. And out of this 25, 5 may be admitted. And you have got enough money. Out of 1,000 people, 5 is admitted in a hospital. And if it is possible for you to give the money for that 5, it is fine. But what is the situation in Kerala? Out of 1,000 people, the morbidity is as high as 350. 350 people are having morbidity. Out of this 350, suppose 100 people are coming to hospital and 25 is admitted. Then for an average Indian, you have to think about 5 out of 1,000. But in Kerala, we have to think about 25 out of 1,000. And if you need 5 times the money to run the program in Kerala compared to any other part of India. Maybe I'm saying Kerala as another state. Maybe what the situation in Kerala is almost applicable for Tamil Nadu. So Kerala is actually an example state. So if your community or if your people are more morbid, one thing. Second one, if they are aware of the program and their rights, and if they are able to claim the money. Suppose Prime Minister of India is saying that, okay, we are giving you 5 lakhs rupees, maximum 5 lakhs rupees for your family. And if you are hospitalized, you can claim that money. Okay, most of the Indian citizens are not aware of that kind of a proposal at all. But in some areas, if the people are able, or people there is strengthening among people has happened. From the next day onwards, they will argue for the money that is promised by the Prime Minister. So that is happening in Kerala. So Kerala government find it is very difficult to implement Ayushman Bharat in Kerala because from the next day onwards, people were seeking for money. Okay, I have got maybe the treatment expense was 4 lakhs. The Prime Minister of India said that I can avail maximum 5 lakhs when you are going to give that money, or even you are going to settle the amount. So Government of Kerala find that it is very difficult. So Government of Kerala devised another program, that is Karunya Arogya Suraksha Paddhati, that is CASP. Okay, whatever money given by central government will be pooled into CASP. Kerala has got a Karunya lottery scheme, so that so much money is coming through that lottery. It is also pooled. And another some dedicated grants are coming, maybe tribal health grant or something like that. Okay, that is also pooled. And we have got our RSBY scheme, and RSBY scheme has got some money. Just like if you go for a premium, you will get a small amount of money has to be paid for that. That amount is also pooled. Whatever amount is there available in the health services or health sector is pooled, and it is made in a common pool, which is known as CASP. Now in Kerala, COVID care for poor is taken care of by CASP. That is actually a very good idea. That is a very good idea where a government is trying to help people by using the existing schemes. So that kind of an experience is actually something great, and that has to be shared. So I'm not putting Gujarat model to just make, to just a comparison. Gujarat is not a state's name. It is actually something insurance or money-driven approach, and Kerala is also not a state's name. It is an area where a community-driven approach is there for health. Okay, Kerala model of health is often discussed in by many economists, that health at low cost. Okay, in Kerala, the Kerala health model is something to be studied, because it was not happened now. It was, most of the people argued that Kerala model has happened because of the good governance by the kings who ruled Kerala. But actually it is not, because at the time of independence, definitely the situation of Kerala was better than the rest of India, but it was not much better. If you consider the infant mortality rate of India as a whole, at the time of independence, it was somewhere around 250. But in Kerala also, it was more than 100, even at that point of time, the time of independence. And even in the Malabar was a part of British presidency, that is Madras presidency. And the infant mortality rate of Madras presidency was almost comparable to that of rest of India. The reduction in infant mortality rate or other gross health improvement has happened only after independence. So it is something happened in Kerala after independence, maybe because of the good governance. So many things are there that we have to discuss based on the social determinants of health. The interesting thing about Kerala model of health is there is no single health program was implemented and was responsible for Kerala model of health. Kerala model of health was the health outcome of the interventions in education, interventions in agriculture, intervention in women empowerment, intervention in other social reforms. The one peculiarity of health is that whenever you put money, wherever you do something good, you will get the positive fluctuations in health. That is a very important and a unique feature of health that we all have to be understand. Suppose you go and improve the sanitation, you will get the influence or the impact on health. You go and improve agriculture. You go and teach people that how to live and how your children should be taken care of, or you just give them some money, especially for women. Yeah, definitely all these things will be getting an impact on health. That means if you want to improve the health, the health programs are not absolutely needed, but you need developmental programs. Another important aspect, I think we have to discuss about the 72 and 73rd Constitution Amendment. And That is a very important aspect where the Panchayati Raj Nagarapalika, that is the Municipal and Panchayati Act, has came into existence. And wherever the provisions of this act was taken care of or used well, those communities were improved in their health status. Even in Kerala, that we now know that the COVID fight is taken care of at the grassroots level by decentralized planning. And this is a very important aspect that Kerala or in India can adopt. Most of the other places has also adopted, and some of the places are actually lagging behind. And it is very much close to the Gandhian concept of Gram Swaraj and all. It is very close to the primary health philosophy also. That means each and every people in a local community, they are electing their leaders. With the help of their leaders, they are discussing their own problems. If they do not have the capacity to learn their own problems, they will get the capacity from outside, and they will learn, and they will actually suggest their own mitigatory activities for the problems, and they will survive. So that kind of a mechanism is very important while you are practicing in India, that how can we use the Panchayati Raj system, how can we use the local governance, how can you use the decentralization are very important. I am not going to details of the Kerala model and the indicators that you can see. I can share the slides and you can see and compare. This is all National Family Health Survey 2000, published in 2017. But we have got some issues also that everybody knows. Okay, we look at the malnutrition. We look at undernutrition. Undernutrition among women. In India, it is 22.9%. Kerala, it is only 9.7%. Undernutrition among men. In India, it is 20.2%. In Kerala, it is 8.5%. Okay, that is actually a very good thing about Kerala. You look at the overnutrition. Okay, women overnutrition in India, it is 20.7%. And in Kerala, it is 32.4%. Even again, men undernutrition. It was in India, it is 18.6%. In Kerala, it is 28.5%. You compare NFHS 3 and NFHS 4, men and women, you will see that in Kerala nowadays, men are becoming more and more obese. Usually, women are becoming more and more obese, and it is a very it's actually a shared problem with all communities which was socially backward or economically backward ones. In African countries also, they are seeing the same kind of a problem. So obesity and overnutrition is coming up anything, especially among females. But in Kerala, it is happening in males also. So that is another aspect of these kinds of things that we have to take care of. This is Dr. C.R. Soman, who have done extensive works on Kerala model. So this is the change that happened in 1956. You can see that the change was not happened during the period where kings ruled Kerala. It is actually happened while we people ruled ourselves. So that is a very important aspect. But so many things are happening. Whatever things happening in Kerala is actually happening all other places of India. And if it is not happening, definitely it is going to happen, maybe in the next 10 years. Okay. From cholera and waterborne diseases, we are moving to diabetes and cardiovascular diseases. From worm infestations and scabies, we are moving to, again, newer generation problems. Old problems were pancreatic diabetes, pancreatitis that we have already discussed, thyroid swellings, and all these problems. But now we are moving to diabetes, biodegradable solid waste. Okay, our waste is becoming is a big issue, and most of the diseases are coming out of solid waste. Most of the communicable diseases you can directly or indirectly link to solid waste. Okay, because of the consumerism and all other problems. Lack of physical exercise and high fat mass. Epidemic of psychiatric diseases and suicides are increasing. So there is an epidemiological shift that is happening, and it is going to happen while your community is going for prosperity in terms of health. So we are going to face new problems, and we have to answer new problems. And you can see that Kerala is, okay, you look at the graph and you can see the rates of Kerala is more than that of USA and UK in terms of cardiovascular diseases. Okay, Dr. C.R. Soman again conducted some studies, and he suggested, and he found out that in Kerala population, the incidence rate of heart attacks was around 500 per lakh. It is more than that is happening in United States and United Kingdom, and it is almost the highest of the world. And then he took the statistic of stroke, and he found that stroke, one of the countries which has got high incidence of stroke is Japan. Japan has got an incidence of 80 strokes per 1 lakh population per year, but in Kerala it was found more than 100. So you may be heard about something called the Japanese paradox. There is an epidemiological phenomenon known as Japanese paradox. Japanese paradox means while all other people are dying because of myocardial infarction, Japanese people are dying because of stroke. That is known as Japanese paradox. The incidence of myocardial infarction in Japan is very, very low. For that matter, wherever heart attack, because both are actually the diseases of your blood vessels. If the thrombus is preferring the blood vessel to your heart, it less prefer the blood vessel to your brain. If the thrombus prefer blood vessel to your brain, it seldom prefer the blood vessel to your heart. So if you look at the incidence of death in US, you may find that cancer may be the number 1, heart attack may be the number 2, and stroke will be very much down the line. If you look at Japan, you may see stroke is very high, but the cardiovascular diseases are much less. But in Kerala, both are very high, and it is actually higher rate than that of US and that of Japan. For diabetes and hypertension and all other cardiovascular diseases, the same thing happening in Kerala, and it is going to happen in other part of India. And because of the Asian Indian ethnicity, what we are going to face is the biggest burden of cardiovascular diseases like hypertension and diabetes, and cardiovascular events like heart attacks and stroke. Definitely, cardiovascular diseases or events may be modified or may be managed by newer techniques like your angioplasty, angiography, and all other things. And it will call for the new facilities. Because of our highly corporate privatized health system that is prevailing in India, people may make money out of that because of the epidemiological transition. But as a doctor, an Indian doctor, it is, or a person working in public health, it is our duty to prevent these kinds of adverse events. So we are actually given with that kind of a huge responsibility that we have to prevent these diseases using community-based programs. Maybe, as we have already discussed, whatever facilities available in the community, we have to use that. We have to get the leadership that is available in the community. We have to teach people and how they can lead a healthy life. we have to make our system so that people will lead their life healthy. So many things that we can do. Whatever things we have done so far to control communicable diseases. You look at the national health programs of India, you will see that almost all of national health programs are on communicable diseases. You may get a couple of programs maybe in non-communicable diseases, for example, National Mental Health Program. And we have got a national non-communicable disease control program, but that is an umbrella program targeting all communicable disease. It is actually combining diabetes, hypertension, stroke, heart attack, and even cancer into a single program. So we may need more comprehensive but more detailed programs so that our public health people all over the nation can get a room so that they can work and they can get the help of the policymakers and they can control the entire paradigm shift of diseases. So this is the thing that we are going to face, rather than now we are facing a problem, or in Kerala we faced a problem of cleanliness of food in the past. Now, rather than the cleanliness, food will be clean, but you have to look at the content of food. How much fat is there? How much trans fat is there? How much preservatives is there? So many things. And cleanliness of water, rather than you have to go to the content of water. It is not lack of food, but food surplus and food, but in certain amount, food scarcity. It is inequity in food distribution. Smoking is coming down, but alcoholism is going up. Personal hygiene is going up, but social hygiene is going down. Occupational injuries are actually going down, but road traffic accidents are going up. Homicides are coming down, but suicides are going up. Death is coming down. At any cost, we will prevent death, because to preventing death means you are earning money. Okay, because if you can prevent the death of a person, definitely he is highly morbid, and again you will come to your hospital and you can make money out of that. But if you are going to prevent disease, that means you are cutting down the money for the corporates. Okay, so we are actually, a person who is working in the preventive side is working against a market economy. So that is a very big challenge. So from pediatrics, it is changed to geriatrics because pediatric population is coming down. But the pediatric care is going to be costly. That is another thing. From absolute poverty, we are moving to relative poverty and all of things. Okay, health expenditure that we have already discussed, and maybe India, the average, this is the National Health Account statistics. Kerala is the #1 per capita spending in health. The healthcare cost is going up like anything. If you look at the statistics maybe for the last 25 years, you will see that this is peaking like anything. And maybe UHC will give you some kind of an answer. And I'm not going to details. Okay, this is in Kerala. We are doing a program which is known as Ardram, that you may be knowing about. The Ardram is the dedicated program in Kerala Health Ministry to achieve SDG goals. Okay, so it is in Malayalam. If you are not able to read Malayalam, the infant mortality rate should be reduced by 8 by 2020. That means this year. Now it is somewhere around 10. It has to be reduced, but because of COVID, sometimes the infant mortality rate might have gone up. That is the suspicion by everyone. Again, maternal mortality rate has also got this problem. It was somewhere around, it was less than 50, but our intention was to make it less than 30 by 2020. Again, because of COVID and all other system constraints, we think that it has slightly gone up. And hepatitis should be eradicated completely by hepatitis vaccine, especially hepatitis B, and complete eradication of leprosy, complete eradication of tuberculosis. That is, it's a big challenge. I don't think it is possible by 2020. UN is aiming to achieve in 2030. That is also a very difficult this target, almost impossible to achieve. But in Kerala, we are not able to achieve by 2020. If we are going to achieve it by 2030, maybe okay, but we have to go for very stringent strategies for that. What are things that we do in tuberculosis is not very efficient to achieve that kind of a goal. So tuberculosis is a cunning disease and it is very difficult for us. Again, we are aiming to reduce or eradicate indigenous malaria by 2020, and that may be possible. And we are aiming to ensure mental health for all again by 2020. All these things are the SDG goals for Kerala by 2020, but because of COVID, sometimes it may be redefined. So these are the things I think is there from me to discuss, and I am stopping my lecture here. And if we want to discuss something more, that now we can discuss. Thank you.
Thank you, sir, for that brilliant lecture. I don't think any of us noticed the time going, and you explained in such detail and made it so effortless for us to understand everything, including the background of primary healthcare, its framework, the foundation of primary healthcare, and the current scenario of universal health coverage. And now the session is open for discussion. If anyone wants to ask their queries directly to sir, now is the time. Does anyone have any questions?
Hello. Thank you, sir, for that wonderful lecture. I just had a doubt. So am I audible?
Yeah, please.
Okay. So you told that there was a shift of the philosophy in primary healthcare during in the report that was submitted in 2008, the World Health Report. You told that there's a change from centralized top-down management to pluralistic health system. So can you just please explain, sir, what is this pluralistic health system?
Okay. Pluralism means rather than depending upon a single factor, you are depending upon many factors. That is the meaning of pluralism. It can happen in different dimensions. For example, to upliftment of a community health, usually we will think that the money should come from the center, but it may not be always true. You can find your own income generation. Maybe that is the example that is given by Kerala Arogya Pathadi, that is CASP in Kerala. That means if you are if it is not the government's responsibility alone, or the target is not fixed by the government alone, target can be fixed at the local community, and the strategies are not planned by the government. It can be planned by the local community with the help of others, and you can have your own mechanisms. Okay, for example, suppose you are working in a PHC area. So in that PHC area, DMO or district medical officer or the state health is giving you a target. Okay, you have to achieve this particular, you have to reduce the dengue outbreak or dengue cases by this much number by this time, and you are given some strategies and you are given money and all those things. So, but rather than that, you have to plan by your own, and you can get the help of others, and you can have your own targets, and you can do the work according to the PHC, the need of PHC that you have. Okay, similarly, in primary healthcare also, for local communities, it is not a top driven approach, rather than you have to use whatever available resources with you, and you have to develop your own strategies. Okay, whenever you look at the original reports, that is in 1978, you will see that it is giving more emphasis to the government. But in 2008, they are saying that definitely, yes, it is the responsibility of the government, but you need not wait for the government to address some of the health issues that you have as a community, and you can develop your own strategies with the help of all other resources that you have. Maybe an NGO will be there, you can use that. In Kerala, sometimes you can have other community-based organizations like Kudumbashree, or you can have your own maybe other alternative medical systems like Ayurveda, Homeo, and all other things. Whatever things available, you can do by your own, by getting help from different stakeholders. That is the meaning of that.
Okay. Thank you, sir. Thank you, sir.
Does anyone else have any questions? Please use the raise your hand option if you want us to unmute you.
Hello, sir. Am I audible?
Yeah. Please. Please, you are audible.
Okay, sir. So in the UHC cube, there's a gap that needs to be, the aim of UHC itself is to fill the gap in the UHC cube. Sir, I wanted to ask that in your experience, what can be done by utilizing the resources that are present right now? Sir, what all can we do to make progress in that area? That's the question.
Okay, thank you. First one, we have to define what is our UHC cube, the outer cube. Okay, the outer cube doesn't mean that it is all services available in your vicinity. It is actually all the essential services or all services taken care of, ideally should be taken care of by UHC, is the outer cube. For example, I have got a heart attack, okay? Then I have to get an angioplasty done. That is an essential care needed, as evidence-based care that is needed for me to save my life. Okay. And according to UHC, it is the responsibility of the community or the system to provide that service. Okay, in another example, suppose I don't feel good, so I want to get an Ayurveda massage. So I am asking UHC to provide money so that I can go for an Ayurveda massage. It may not be addressed in the UHC at all, because it is only your choice. If an evidence showing that you have got a problem and this problem could be addressed by Ayurvedic massage, there is no more efficient program other than Ayurvedic massage to address your problem. Then only Ayurvedic massage will be there in the UHC. Otherwise, the Ayurvedic massage will not be there in the UHC. So, in UHC, the first step is to determine what are the services that should be there in the UHC. Ideally, that should not be based on the resource constraints, but practically it is based on the resource constraints also. So each and every government will give a list of services that is there in UHC or that should be there in the UHC. That is the exercise that has to happen first. Then we will define the first cube, that is the outer cube. What are the services? How much money should be there to provide all these services for our population? How much of the population is there totally to be covered, and all those things should be defined. Then again, we have to conduct a survey, or from the secondary data analysis, we have to find out that, okay, out of these services, how much services is already taken care of by any of the pooling mechanisms. There may be many different pooling mechanisms will be there. Mainly, there are two pooling mechanisms in most of the countries. One is the tax-based, is this health services. For example, you are giving income tax and government is generating many amount of money and they are providing something. For example, your primary health center, okay, in your locality may be given, there will be some doctors, you can get the treatment from those doctors. There will be some drugs available in that hospital. All these things will be given to you free of cost, but the cost for this doctor, the doctor's salary, maybe the cost for this drug is taken care of by the tax amount that is the government has already taken from its citizens. So that means a particular amount of services are already covered. You need not pay money for that. For that kind of, sometimes you may get an insurance, RSBY insurance or something like an insurance, and it will cover certain services. Okay, what are the services that is taken care of by RSBY scheme? And all these things are listed out, and we are drawing the inner cube. That means, okay, you cannot actually precisely say that there will be some lack of consensus in certain areas, but conducting a research with a good amount of precision, we will draw the inner cube. Then we will take the difference between the outer cube and inner cube, and we will just estimate the money that is needed to make your inner cube as big as the outer cube. And that is the amount of additional investment you want to put in UHC so that your UHC will be a success. That in fine morning, you cannot make your inner cubes as big as the outer cube. It gradually is going to grow, and each and every steps you have to monitor, and you can include more and more services so that your inner cube will gradually grow to the outer cube. Maybe in the first 5 years, you may be increasing your cube size by 10%. It may be fine. Then you have to prioritize what are the things that should be included to make the cube size more than 10%. In certain countries, there are certain organizations is helping for the UHC cube to grow. For example, in Britain, NICE is doing such an exercise. In Thailand, there is an organization known as HITAP is doing that exercise. In India also, there is some organizations, but it is not full-fledged. And but we are in a rudimentary stage. Definitely, a lot of research should be there, a lot of data should be there to define the outer and inner cubes of UHC.
So in effect, you are saying that there should be initial needs, initial presentation of the scenario should be understood, and the needs assessment of the community should be done, and the fund allocation according to the needs should be done, and then the gap should be filled over time, and continuous monitoring and evaluation should be continued. Is that right, sir?
Perfect. Again, for different sets, there will be different things. For example, suppose I am a pediatrician. So I think the neonatal mortality because of cardiac morbidities are high. UHC should cover the Fallot's, the surgery of Fallot's tetralogy. That is a very important aspect for me as a pediatrician. Then I will give a proposal to UHC. You have to consider this service should be there in the UHC because of these reasons. There will be a committee, and committee will will look at the evidence. Okay, how much children are subjected to the surgery? How many people will be benefited out of the surgery? How much money should be there to be spent? What is the value maybe of that money? How much? What is the advantage out of that? What are the conflicting ideas that is available to us? What money is there with me? What is the output I can make? I am using the money for this proposal compared to other proposal. And all these things should be exercised. Then only our UHC can be grown to the other further level. What you have said is right and it's excellent. Thank you.
Thank you, sir.
Due to restriction of time, we're ending the discussion session here. Thank you, sir, for being our first guest in this webinar series. I'm sure everyone found it as much informative and enjoyable as we expected. Thank you, everyone, for joining us today. We hope to interact with you again next Thursday at the same time as we discuss the various health programs with Dr. Rashmi MS, Deputy DMO of Pathanamthitta District. We wish you all an enjoyable evening.
Thank you. Thank you all.